students, I'm Dr. Gayatri, and today we are going to talk about nursing care of children with some musculoskeletal and neurological disorders. So first of all, we'll see the disorders in the musculoskeletal system. So before starting with the disorders, first we'll see what the musculoskeletal system is. So as the name itself suggests, musculo refers to the muscles. Skeletal refers to the bony skeleton. So you can see in this picture, this is the bony skeleton of the human body, and in this you can see all the muscles attached to the bony skeleton. So these muscles and the skeleton, bony skeleton together forms the musculoskeletal system. So under musculoskeletal system disorders, we are going to look at two conditions. One is fractures, the other one is osteogenesis imperfecta. So this osteogenesis imperfecta, in shortened form you call it IO. So this condition is also known as brittle bone disease. So first we'll see fractures. Now here you can see the bone has broken into two. The bone has broken into two. See? These are here both the bones, tibia and the fibula, they have broken into two. So that means when the bones break into fragments, that is what we call fractures. So first of all, we are going to look at fractures. So what are fractures? Fractures are broken bones. Now sometimes when a bone is fractured, it may be associated with a break of the skin or breach in the skin through which the fractured bony particles protrude out. So in that case, that is called an open fracture. Sometimes there will be a fracture in the bone, but the skin remains intact. There is no wound on the skin, so that the fractured bony particles do not protrude out of the body. So those fractures are called closed fractures. So sometimes when there's a fracture, there may be a slight simple crack on the bone, but the bone is not separated into bony fragments. So in that case, you call it a non-displaced fracture. Or sometimes when there's a fracture, the bone will be broken into bony fragments. So in that case, you call it displaced fracture. So non-displaced fractures do not give rise to any deformity, but displaced fractures give rise to deformities. So if the overlying skin is intact and the fractured bony particles are not exposed to the outside, those are called closed fractures. And if there is a breach in the skin through which the fractured bones are protruded out, those are called open fractures. So here you can see it's a fracture with an obvious deformity in the forearm. So this is an open fracture. You can see there's a wound in the skin, a breach in the skin through which the fractured bone has come out. So it's an open fracture. Okay, so now since this is a pediatric module, we are going to discuss about fractures in children. So in smaller children, younger children, when they are playing or when they are walking, when they start to walk, if they fall down on outstretched hand, they can get fractures. But when it comes to older children, they do sports, they do cycling. So during these activities, their bones can get fractured. So childhood fractures mostly occur in bones like clavicle, ulna in the forearm, tibia in the leg in the leg, and femur in the thigh. Now the commonest of all these childhood fractures, these are fractures in the distal forearm, that is in the distal end of the radius and ulna. So there are some typical types of fractures which you see in children. What are they? Bends, buckle fractures, green stick fractures, and complete fractures. So we'll see what they are. So first, bends. What do you mean by bends? That is, now in a child, the epiphyseal growth plates have not yet closed. So therefore, the bones are still growing. So these growing bones, they can bend by 45 degrees or more before they break. So that is called bending. So bends are usually seen mostly in ulna and in fibula. So in ulna in association with fracture of the radius, and in fibula in association with fracture of the tibia. So if you look at this picture, you will see this is the bending. See, the bones are not straight. There's a bending, right? So this is what you call bends. Next we'll see the second type of common fractures in children, that is buccal fractures. So what do you mean by buccal fracture? Now it's a compression in the porous part of the bone, making a small bony projection that looks like a buccal if you look at it from outside. So in most of the time, now if you look at this picture, you will see this is a buccal. So you can see a bony projection in the it's a small projection in the bone. So where is it located? Usually closer to the most porous end of the bone. So what is the porous end of the bone? That is the metaphysis. So metaphysis, now the ends of the long bones, these are called epiphysis. The shaft is called diaphysis. So in between epiphysis and metaphysis, the area is called, in between epiphysis and the diaphysis, the area is called metaphysis. So metaphysis has got a good blood supply and also a good nutrition supply. So that is why it is the growing end of the bone. So most of the time in buccal fractures, this compression occurs in the metaphysis, which is the most porous area of the bone, and it looks like a bony projection from outside. So this is buccal fractures. Third type is called green stick fractures. So what are they? Now green stick fractures occur when a bone is angulated beyond its normal limits of bending. So then when a bone bends, what happens is there are two sides of the bone. So when a bone bends, there's a compression side and then there's a tension side. So then the compression side will bend and the tension side will fail to bend. So then what happens is it gives rise to an incomplete fracture in the bone. So this is what we call green stick fracture. So green stick fractures, why do they occur? That's when the bone becomes angulated beyond its normal limits. The fourth type is called complete fracture. What do you mean by complete fracture? When a fracture breaks a bone into bony fragments, that is called a complete fracture. Now if you look at this picture, you can see the bone is broken into two. So that is a complete fracture. So now what are the signs and symptoms of fractures? There will be an obvious deformity in that area. There will be tenderness. First of all, there will be pain. That is, the patient will feel the pain, and at the same time, if you touch that area, it will make pain. So it will cause pain. So that is called tenderness. There is muscle guarding, swelling in that area, bruising or redness in that area, abnormal sounds, crepitations in that area, then movements, abnormal joint movements. Then if it is an open fracture, the bony fragments may be exposed to the outside, and sometimes the movements will be lost. So these are the symptoms of fractures. Okay. So now we'll see how the fractures are assessed based on history, physical examination findings, and investigations. So history, what is that? You have to know about the mechanism of injury. That is, you have to know the circumstance of injury to get an idea about what type of musculoskeletal injuries the patient has undergone. Next, you have to have an idea about the pain. So the pain, whether it's localized to the fracture area or whether it covers a wider area than that. Then the intensity of the pain. Using a pain scale, you should be able to assess the patient's pain from a scale of 1 to 10. Then quality of the pain, onset of the pain and duration of the pain, whether the pain is static or whether it had been there constantly, or whether the pain is increasing or whether the pain is decreasing. Then progression of the pain, that is. Next, you have to know whether the pain is localized to that area or whether the pain radiates to some other parts of the body. And at the same time, you should know about the aggravating factors and relieving factors of this pain. And sometimes when there's fracture, the blood vessels and the nerves surrounding that bone may also get damaged. So in that case, the sensations will be lost, and then the blood supply to the areas distal to the fracture will be lost. So in that case, there will be coldness, paralysis of the limbs, as well as sometimes the limb tissues, the muscles over there can die. So you have to also ask the patient about any loss of sensations or any coldness or paralysis of the limbs, of the affected limb, right? Okay, so then the physical examination, what I'm going to look at, there'll be swelling in that area, abnormal positioning, then abnormal movements. Then you have to check the neurovascular status, proximal and distal to the fracture. And all these signs and symptoms should be confirmed by doing a investigation. So what is this investigation? Most of the time it is a X-ray. So now we'll see the medical interventions in fractures. So what are the medical interventions? You have to control pain, hemorrhage and edema. You have to relieve muscle spasms. You have to, if the bones are displaced, if the bone fragments are displaced, you have to realign these bony fragments, the fractured fragments, and then you have to splint them to immobile them, to make them immobile in order to promote early healing. And at the same time, you should take care of secondary complications, especially when it comes to splinting. If it is not applied in a proper way, it can give rise to a lot of complications. So you have to take care as far as possible to overcome these secondary complications. And you have to limit disuse syndrome. When part of the body is not used for a long time, that area becomes dysfunctional with time. So this is called disuse syndrome. So when a person, due to a fracture, that part of the body is immobilized, then it can cause disuse syndrome. So you have to take measures to limit this. That is, you should make the patient heal properly within a short period of time, so that they are able to resume their normal movements early, right? So restoration of the function, that is. So now we'll see the nursing diagnosis in fracture injuries. Acute pain due to injury, risk of skin integrity related to treatment, that is most of the time due to application of splints. So that is why splinting has to be done very carefully. If the splint is too tight, it can cause a lot of damage. If it is too loose, it's of no use. If it is too tight, it can cause damage to skin and underlying tissues. So that is why it has to be applied with care. Next, you have to assess the risk of infection, especially if it is an open fracture through which the bone fragments are exposed to the outside through an open wound. Next, you have to immobilize the fracture to promote early healing. You should educate the patient about the treatment, why it is important, and about the outcome. So these are the nursing interventions in fractures. You have to maintain proper alignment of displaced bone fragments. Then you have to monitor the neurovascular status, proximal and distal to the fracture, promote mobility, and once the patient is about to be discharged, you have to plan their discharge, and also you have to educate the patient as well as the family about how the patient has to be taken care of when he is at home. So that's about fractures. So now we are going to look at another musculoskeletal disorder in children. So that is called osteogenesis imperfecta. So in shortened form, osteogenesis imperfecta is written as OI. So osteogenesis imperfecta is also known as brittle bone disease. So we'll see what that is. So osteogenesis imperfecta is a connective tissue disorder that affects the bones. So here the problem is the bones become too fragile and they break up easily. So here are the clinical manifestations of osteogenesis imperfecta. So there will be multiple frequent fractures. Blue color sclera. Sclera is the white portion of the eye. Now in the eye we have the black color portion. Surrounding that we have the white color area. So this white color area of the eye, which you can see from outside, is called sclera. So in a normal person the sclera is white in color, but in brittle bone disease or osteogenesis imperfecta, their sclera is not white, it's bluish. So blue sclera. Thin soft skin, increased joint flexibility. There will be enlarged anterior frontanale, weak muscles, soft, weak, easily breakable bones, that is brittle bones. They have short stature. Now if you look at this, you can see these are x-rays taken in a person, in a child with osteogenesis imperfecta. So you can see all the bones all over the body are deformed and they are abnormal, so they can easily fracture. And if you look at this, this is the blue color sclera. So this is the sclera. In a normal person it's white, but in brittle bone disease or osteogenesis imperfecta, the sclera is blue in color. So now we'll see the nursing management in osteogenesis imperfecta. So you have to educate the parents as well as the child about the disease condition and how it is treated. Now they have bone abnormalities. Their bones are weak, fragile and easily fractured. So most of the time they have multiple fractures. So their skeletal growth is not normal. So if the child is having osteogenesis imperfecta, the nursing staff should be monitoring their growth properly, as well as you have to assess their development. That is, now development is what are the activities you can do with time. So these activities in a child with osteogenesis imperfecta is limited compared to a normal child of the same age. So you have to do a developmental screening as well to see how much of developmental milestones they are able to achieve with time within their limitations. Next, these children, since they have very fragile, easily breakable bones, whenever you're handling the child, it has to be a very gentle handling to prevent fractures. And you have to, now they have frequent bone fractures, so when they fracture they have to heal. So this healing process requires vitamin C, vitamin D and calcium. So that is why these children should be given a balanced diet with extra vitamin C, vitamin D and calcium to help bone healing, help healing of the fractures as well as to promote bone growth. So that's about osteogenesis imperfecta, a condition where a connective tissue disorder where affecting bones, where the bones become too fragile and easily break. Now we are going to look at some malformations in the central nervous system. So nervous system has two main components. We have the central nervous system and we have the peripheral nervous system. So brain and the spinal cord together is called the central nervous system. So arising from the brain, we have cranial nerves. We have 12 pairs of cranial nerves. And arising from the spinal cord, we have spinal nerves. We have 31 pairs of spinal nerves. So these cranial nerves and spinal nerves together is called the peripheral nervous system. Right? So we are going to discuss about malformations of the central nervous system. So you have to know about the central nervous system. So what is it? That is the brain and the spinal cord. So from where does it develop from? When the baby grows inside the mother's uterus, that is during embryonic life, during the early stages itself, the central nervous system develops from the neural tube. So look at this. This is the brain and the spinal cord. This is called central nervous system. Right. So now we'll see neural tube defects. Now what are they? Now I have told you during early embryonic life, the central nervous system develops from the neural tube. So when the neural tube does not function properly to form the central nervous system, it can give rise to some defects in the nervous system in that child, or some defects in the central nervous system development. So these are called neural tube defects. So these are some neural tube defects: anencephaly, spina bifida, then encephalocele, right? So these are examples for neural tube defects. So spina bifida. Spina bifida is of two types. One is called spina bifida occulta, the other one is called spina bifida cystica. So spina bifida cystica, it includes meningocele and myelomeningocele. Now look at this picture. This is spina bifida. This is spina bifida occulta. Occulta means it is not visible from outside. So this is spina bifida occulta. So there's the defect is not seen from outside. So if you look at the child's spine from outside, there's nothing abnormal to be found. Sometimes in that area there will be a tuft of hair, sometimes there can be a slight lump. Apart from that, there's no bulging or any other abnormality. And also the child's all functions will be normal. The spinal nerves will function in a normal way. So this is the least affected type of spina bifida occulta. Now if you look at these two pictures, what can you see? This is how the second and third conditions, meningocele and myelomeningocele, would look like from outside. So there will be a soft bulging on the outside of the body. So that's spina bifida cystica. So it's a cyst-like structure lying outside the body. So that is why you call it spina bifida cystica. So spina bifida cystica is of two types, meningocele and myelomeningocele. So what is meningocele? Now we know surrounding the central nervous system, surrounding the brain and the spinal cord, we have meninges. We have 3 layers of meninges. So when these meninges protrude out and appear as a bulging on the baby's spine, that is called meningocele. Sometimes not only the meninges, along with the meninges, the spine can also protrude out and can remain as a bulging on the baby's spinal region. So that is called myelomeningocele. Myelo stands for spinal cord, meningo stands for meninges. So these meningocele and myelomeningocele, these are the dangerous types of spina bifida. The most dangerous one is the myelomeningocele. So this is how meningocele and myelomeningocele would look like if you look at the baby from outside. Right. So now we are going to discuss about myelomeningocele. So what is myelomeningocele? That is it's the most common birth defect of the central nervous system. So this is a real picture showing how the myelomeningocele looks like. So myelomeningocele It accounts for more than 90% of the spinal lesions. And myelomeningocele is not an isolated defect. Most of the time, it is associated with other malformations like hydrocephalus, syringomyelia, and hip dislocation. The exact etiology for myelomeningocele is not known, but researchers have found that there is an association with maternal folic acid deficiency during pregnancy. That's because the folic acid is required for the normal development of the neural tube. So if the mother has got a folic acid deficiency during pregnancy, what happens is the baby's neural tube will not be formed properly. So then the central nervous system formation will be defective. So it can give rise to various neural tube defects. So since the nervous system development from the neural tube occurs in the early stages of pregnancy itself, if you want to overcome the risk of neural tube defects, the mothers need to have folic acid before they plan their pregnancy itself. So ideally, they need to start folic acids 3 months before they plan their pregnancy, because then by the time they become pregnant and the baby's neural tube starts to grow, the mother will have enough of folic acids in her body. So usually for mothers, 1 milligram per day of folic acid is recommended to overcome the problem of neural tube defects in the baby. But if a mother has delivered a child with a neural tube defect in her subsequent pregnancies, there is higher chance of neural tube defects in the subsequent babies, and therefore in those mothers 1 milligram per day of folic acid is not enough. For those mothers, you have to give a higher dose of folic acid. Usually 5 milligrams per day of folic acid needs to be given if there is a history of a previous child being delivered with a neural tube defect. So this is 1 milligram per day of folic acid recommended to all mothers. Ideally has to be started 3 months before they plan their pregnancy. And if there is a history of a previous child with a neural tube defect, then 1 milligram per day is not enough. You have to increase the dose to 5 milligrams per day. Now, myelomeningocele can be diagnosed during pregnancy itself. So during 16 to 18 weeks by amniocentesis. That is, you insert a needle into the amniotic sac and you draw some amniotic fluid from the water bag, the amniotic sac. And if you examine this amniotic fluid for alpha fetoproteins, you can get an idea about myelomeningocele or neural tube defects. The other thing is anomaly scan. Now, anomaly scan is not a routine ultrasound scan you do in pregnant mothers. So, routine ultrasound scans are the first scan or the dating scan which you do in early pregnancy to see the age of the fetus and to see when the baby is going to be delivered. And then the late stage pregnancy, you do another ultrasound scan to see the growth of the baby and the location of the placenta, as well as to see the position of the baby. So these are the two mandatory ultrasound scans in most countries. Anomaly scan is not mandatory. It is a scan where all the baby's body systems are assessed system by system between 18 to 22 weeks of pregnancy. So this is not recommended in all mothers. This is recommended in several conditions. One is if a mother has delivered a child previously with some congenital malformation, then they are offered this anomaly scan. Another condition is mothers at risk of developing congenital malformations, developing babies with congenital malformations. So if there is any risk in those mothers, you offer the anomaly scan. So by doing the anomaly scan, you can get an idea about myelomeningocele. So this is how this is how the myelomeningocele would look like in an ultrasound scan done during pregnancy. Okay, so after birth, how is it diagnosed? It's quite obvious. It's an obvious uh, soft bulging which you see on the back of the newborn. So it's an observable physical finding. So this is how the myelomeningocele would look like. Right. So now we'll see the clinical manifestations of myelomeningocele. So there will be loss of bladder and bowel control. That is below the level of the spinal, below the level of this lesion, the spinal nerves will not function properly. So because of that, the bladder bowel control will be lost. There will be partial or complete loss of sensation below the level of the lesion. There will be partial or complete paralysis of legs, weakening of hips, legs and feet. So these are the symptoms. And what are the diagnostic evaluations you have to do? You have to know more about the lesion, the extent of the lesion. So to do that, you have to do investigations like CT scan of spine, MRI of spine and myelography. So now we'll see the therapeutic management in myelomeningocele. So myelomeningocele is a complicated neural tube defect. So to manage that, you need specialists from various disciplines, and therefore management of myelomeningocele is a multidisciplinary approach that involves specialties such as neurology, neurosurgery, pediatrics, urology, orthopedics, rehabilitation, physical therapy, occupational therapy and social services, as well as intensive care nursing. So initial care of the newborn. How should a baby with myelomeningocele be looked after birth? So there has to be careful positioning of the baby. The baby has to be kept head down position, that is in prone position. Why? Because on the back they have this soft bulging of spine together with the meninges. So if you keep the baby on supine position, that is going to be damaged. The spine and the meninges, the bulge will be damaged. So to prevent that, you have to keep the baby in prone position. There should be careful handling of the baby during feeding as well as bathing. You have to take care to prevent infections, and at the same time you should do a neurological assessment, and most of the time they'll be associated with other abnormalities like hydrocephalus and syringomyelia. So you have to look for those associated anomalies. Then you should help the baby to evacuate the bladder. You have to help to pass urine. So how can it be done? One thing is, you apply downwards gentle pressure over the patient's bladder. Then it will help to pass out urine. If that is not successful, sometimes the patient will have to be catheterized. Then how can you help the bowel evacuation? Bowel training as well as high fiber diet. And then you should give physiotherapy, because most of the time below the level of the lesion, the nerves will not function properly, so there can be problems with movements and sensations in the limbs, lower limbs. So they need to be given physiotherapy. So now we'll see the prognosis of myelomeningocele. So the defect can be corrected surgically, but if the neurological damage has already occurred, sometimes it may stay and become irreversible. So here are the nursing considerations in myelomeningocele. So you have to take care of the movements of the extremities, anal reflex, urine output, head circumference, that is occipitofrontal circumference, as well as the frontanale, the condition of the frontanale, whether they are bulged out due to hydrocephalus or whether they are depressed. And you should avoid diapering the baby until the defect is surgically corrected and the surgical wound is properly healed. So until the surgery, you have to take care of the myelomeningocele sac. So this is how you have to look after the myelomeningocele sac. So the first thing you have to do is you have to avoid irritation. To do that, the baby has to be kept in an incubator or in a radiant warmer. And now this is exposed to the outside, the myelomeningocele sac. So you have to avoid it. You have to avoid myelomeningocele sac from getting dried. So to stop this drying up, what you should do is you have to cover it with sterile, moist, non-adhesive dressing. And this dressing cannot be kept in that place for long. So every 2 to 4 hours the dressing has to be changed, and while doing that you have to examine that area properly to see whether there's any irritation, leakage, abrasion or any signs of infection. Next, the surgical correction has to be done. So once the surgery is performed, thereafter you have to catheterize the baby, maintain the fluid intake output chart. You have to assess the vital signs, assess the baby's weight, check the head for occipitofrontal circumference and the frontinalis, and you have to maintain the baby's body temperature. As well as, very important, you should take care to be alert on any signs of infection. So family support, what is that? Once the baby is observed to have myelomeningocele soon after birth, the condition for parents, it's something unexpected. So you have to provide the emotional support for the parents to cope up with the baby's surgical condition. Next, you should encourage the family to get involved with the baby's activities, that is to take care of the baby in the hospital before operation as well as after the hospital, after the surgery. And when the baby is discharged, you should help the parents to stimulate the babies to accomplish their normal developmental tasks within the limitations imposed by their disability. So that is how you have to provide family support if a child is born with myelomeningocele. Right, so that is, we had been discussing about myelomeningocele, a condition where the spine and the surrounding meninges bulge out of the body as a soft mass, cystic mass. Right, so now we are going to look at this condition. This is called hydrocephalus. So if hydrocephalus is present since birth, that is called congenital hydrocephalus. So the incidence of hydrocephalus is 3 to 4 in every 1,000 live births. Now remember, hydrocephalus is potentially fatal until a proper surgery is performed to remove the excess cerebrospinal fluid from the central nervous system to the blood or to the peritoneal cavity. So what are the causes for hydrocephalus? It could be due to overproduction of CSF, cerebrospinal fluid. It could be due to some congenital malformations in the CSF drainage pathway, right? So that the CSF gets accumulated inside the ventricles, causing the head to enlarge in size. Or sometimes it could be a blockage in the CSF drainage pathway, not due to any congenital malformations, but secondary to some injury to the head or infections in the brain. Now, what is CSF? Now, all of you have understood by now, this hydrocephalus is when the CSF formation is either when it's too high or when the CSF drainage does not take place properly. So then what is this CSF? CSF stands for cerebrospinal fluid. So what is that? It is a fluid that is produced in the ventricles of the brain, and it circulates in the subarachnoid space surrounding the brain and the spinal cord, right? So in a normal person, CSF is produced in the ventricles and it flows in the normal CSF drainage pathway. So in that case, the baby's head is normal in size. There is no hydrocephalus. Look at this picture. There's too much of CSF production, or when the CSF drainage pathway is blocked, what happens is the CSF gets accumulated inside the ventricles. So this makes the head to enlarge in size. So this is what we call hydrocephalus. So when there's hydrocephalus, the head is enlarged due to excess CSF accumulated inside the ventricles. So what are the signs and symptoms of hydrocephalus? So there is too much of CSF inside the brain, inside the ventricles in the brain. So this makes the head to enlarge in size. The scalp becomes very thin and shiny. You can see all the dilated veins on the scalp. The frontalis, these are bulged out, and the suture lines in the skull, they begin to separate. Then if you look at the eyes, there is this setting sun appearance in the eyes. There is widening of the bridge between the eyes, and there will be associated features. Now since there is increased intracranial pressure, it will be associated with vomiting and headache. So this is the therapeutic management. So therapeutic management of hydrocephalus targets these things. You have to first of all relieve hydrocephalus, that is, you have to remove this excess CSF from the central nervous system. You have to treat the complications, and at the same time you have to manage the problems that can arise due to hydrocephalus, that is, it can affect the baby's neurological psychomotor development. So you have to address these issues. So this is the target of treating hydrocephalus. So the definitive treatment is shunt surgery. So there are several types of, now what is shunt? When blood from one area is directed to some other part of the body, that is called a shunt. So there are several types of shunt surgeries that can be done to correct hydrocephalus. One is ventriculoperitoneal shunt, VP shunt. That is the best option. So here the shunt is from the ventricle in the brain where the CSF is produced to the peritoneal cavity. Ventriculoatrial shunt, that is VA shunt. That is a shunt from the ventricle of the brain where CSF is produced to the right atrium in the heart. Next thing is LP shunt. So what is LP shunt? From the lumbar space to peritoneal cavity. So out of these different types of shunts that can be performed, the best surgical treatment of hydrocephalus is to perform a VP shunt, ventriculoperitoneal shunt. So look at this. This is a VP shunt. You can see a catheter is sent through the skull to the ventricle. Tube is inserted. So through the tube extends up to the peritoneal cavity. So through this tubing, all the CSF in the ventricle drains to the peritoneal cavity. So this is VP shunt to treat hydrocephalus. So what are the complications of this surgery? One thing is infection, right? So it increases the risk of all sorts of infections, meningitis, shunt nephritis, ventriculitis, sepsis, infective endocarditis, wound infections, right? So these are newborn babies. So we are talking about congenital hydrocephalus in newborn babies. So newborn babies, their immunity is not that good. So there are prone to develop these infections, especially after a shunt surgery where their immunity becomes further low. Next, if the shunt, another thing is the shunt can get dislodged, the tubing can get dislodged, that is also a complication. The next thing is there can be blocks in the shunt. So if the shunt gets blocked, what happens is it increases the pressure inside the brain, so it can alter the brain development as well as the neurological status of the baby. And when the CSF pressure is drastically reduced, it can cause subdural hematomas. Now, in the VP shunt, the CSF all enters into the peritoneal cavity. So this fluid can promote the growth of microorganisms which can cause infections. So it increases the risk of peritonitis, abdominal abscess, and infections can lead, and then tubing or catheterization can damage to the organs in the abdomen, form fistulas, hernias, as well as ileus, paralytic ileus. So these are the complications of shunt injury or shunt surgery. Right, so now we'll see the prognosis. Now I have told you at the beginning of the lesson, hydrocephalus, if untreated, unless it is surgically corrected, it's potentially fatal. Therefore, if hydrocephalus is not treated, the death rate is 50 to 60%. If hydrocephalus is treated, most of the time, in more than 90% of cases, if it is treated, the survival rate is more than 90%. And the mortality is very high within the first 2 years after the surgery. Thereafter, the mortality risk gradually reduces. And when it comes to the surviving children with hydrocephalus, 2/3 of them will have the normal intellectual functions. So now we'll see the nursing considerations in hydrocephalus. Before the surgery, you have to, now it's a condition where the head is growing in size, so you have to check the baby's OFC, occipitofrontal circumference, and you have to look for signs of intracranial pressure like unconsciousness or altered level of consciousness. Now these are newborn babies, so you can't be asking them questions, so you have to observe the baby for their interactions with the environment and their sleep pattern. So that is how you assess their signs of raised intracranial pressure. Next, you have to maintain a proper nutrition and then perform the shunt surgery. So after the surgery, you have to place the baby onto the opposite side of the that is onto the unoperated side of the body. Why is that? If you place the baby on the operative side, it can damage the shunt valve. So to prevent that, you have to position the baby on the unoperated side, and the baby has to be kept flat, not head or foot end raised. And you have to observe the baby for any fits or seizures. For the first 24 to 48 hours after the surgery, nothing should be given orally. You have to give them IV fluids, and you have to assess them for signs of infection. So when there's hydrocephalus, once again, especially when there's congenital hydrocephalus, it's something unexpected for the parents. So you have to educate the parents about the child's condition, and you have to reduce the, when the parents see a baby with a large head, they become confused and they become anxious about what is going to happen to the baby. So you have to teach them about, explain them about the treatment, why we do the shunt surgery, and about the outcome of the surgery. And at the same time, you should train the parents to identify shunt dislodgement or shunt malfunctions and to detect infections early. So in today's lesson, we had been talking about some musculoskeletal and neurological disorders in newborn babies. And thank you very much for listening.